Great, so welcome to this session. We're going to be basically discussing hemodynamics and fluids. And we hope for a lot of open discussion at the end. So Matthias is going to sort of outline why have recent goal-directed fluid therapy studies been negative. I'm going to sort of paint a picture of the latest papers that have influenced practice and come up with a sort of structured hemodynamic framework. Brenton French will be presenting work on AKI and downstream effect. It's just very novel work that he's done. And then once we've answered the why question, he's then going to present the framework that he implemented at Virginia Commonwealth University, which is the how, and whether it was beneficial or not. And then we've got an open discussion. And Tonya is joining us on the stage as well to represent the surgical community as well. So I'm going to ask Matthias to kick off, please, with the venous return, the next frontier in GDHT.
Good morning. Thank you, Mike, for the introduction and for getting the session started. So I have no disclosures. And while I was working in the ICU on these patients, there came out a few papers that are fairly near to my daily practice, which is mostly anesthesia for major urologic procedures, that caught my eye because, number one, there were in radical cystectomy patients, but also because they were negative. So the one to your left, Peter Hanna and colleagues in the Journal of Urology, associated fluid totals with outcome, and found that actually the ERAS cohort had more acute kidney injury. And I'm always wary about these papers because when they come out and people see, then they immediately say the whole thing doesn't work. Sort of the proverbial pars pro toto. So nevertheless, they, however, did not control for pressor use, blood pressure, epidural use, and did not report any ERAS compliance data. So I think they had a symptom, omitted the black box, and then just had an immediate response. ERAS doesn't work. And then the other paper in the anesthesia tabloid, a little bit earlier, they looked at ileus and found that goal-directed therapy did not decrease the occurrence or the duration, more importantly, of ileus. So, but the third paper that's negative that is coming out or has come out is one that probably desires and deserves a little bit closer attention because that is from nobody less than Birgit Brandstrup in Denmark. And that's goal-directed fluid therapy in emergency abdominal surgery. And there was no difference. And I spare you the details in the interest of time. You can review this paper. No difference in mortality, no difference in morbidity, and other things we typically look at, such as length of stay, time in the ICU, time on the ventilator, and so forth, complications. Interestingly, survival curves were different depending on whether there was a perforation or a bowel obstruction, but no difference between the different groups, and their goal-directed therapy consisted, again, like in the other papers, of stroke volume variation guided fluid administration. The pressor use is reported, but not in terms of timing, the goal-directed fluid got albumin as a bolus, which the standard group didn't. The standard group, however, got a little bit more fluids in the almost 3-liter range. So what's going on here? And this is, I can go through this quickly, a quiz. And if you're familiar with these fluid studies as an anesthesiologist, then you probably recognize this by now. This is the first important trial by Birgit Brandstrup in 2003, and she called the liberal too much and restrictive the sweet spot. Later on, this came out, liberal was just right, and the restrictive group was just too little. And that's, that is obviously Paul Miles in 2018 in the New England Journal. So the problem is here that the life is a game with many rules but no referee. And you learn to play it more by watching than by consulting a book. Joseph Brodsky gave this commencement speech in 1988, but it's still worthwhile studying. And he moves on to give us some pointers here, and he says zero on being precise with your language. And I think the description as restrictive and liberal is unhelpful because it's not precise enough. These other things, these other recommendations are important as well and worthwhile. I don't want to go too far in it, but number 5, I think, is super important because at all costs try to avoid granting yourself the status of the victim, because you do, if you put blame on somebody, you immediately forget about your resolve to change anything. And then number 6, if somebody makes your life hard, just flip the channel. Are these trials really disturbing? And yeah, they were disturbing enough that we did write a letter to the Journal of Urology saying, well, wait a minute, you are omitting the black box, and my goal here is to sort of elucidate to you a little bit what the black box is. At the same time, Arne Feldheiser wrote a mini review in the EJA about the vasopressor effect on venous return in septic patients, and yet again that was motivated because of a paper that had come out that showed there was no difference in terlipressin use in septic patients. And we think the setup and ignoring the black box, again, led to these results that otherwise could have been different. So when Arne Feldheiser published this paper about venous return, the response from a few select people was sharp and swift. And Michelle Wu, who was on that, actually got some pretty hefty emails from some of these people calling her all kinds of names. But in the end, it was helpful because it kicked off, again, this debate that's still going on in the EJA. And it was mostly about what drives venous return, even though we didn't even agree in that paper on what drives venous return because Simon Gelman had a different opinion than Arne Feldheiser. But we also said what drives venous return, unfortunately, does not matter to us when we try to do goal-directed fluid therapy and goal-directed hemodynamic therapy correctly. And we even put this disclosure on, saying that we don't agree whether it's the Guyton principle or whether it's arterial impulse that propagates into the venous system that drives venous return. The important thing here is that we are mindful of venous return and what's going on the venous side, and I'm going to illustrate that in my next slide. Simon Gelman has dedicated his life to hemodynamic study, and I highly recommend this publication in 2018 in Anesthesiology, and this drawing really reflects his life's work, which was done from one of the people in Charles Serhan's labs. So, before I go into the venous system, I also want to bring up epidurals because they play a major role in this, and they make this whole thing even more complicated. Not because they're challenging to do, and there's a high failure rate in the literature, and we don't really take the time to get them right, like in OB, meaning we do one shot, right, for laparotomy. And if it works or not, doesn't matter. We go to the OR because it's time. In OB, we make sure it works because the stakes are a lot higher. If that epidural doesn't work and you need to do a stat section, you don't look good, right? In general surgery, it doesn't seem to be that hard. And then the post-op part is difficult too, because if you're hypotensive with an epidural, most likely it's not fluids because the epidural reduces the sympathetic tone in the splanchnic system. And like this paper beautifully shows, and I really recommend this to anybody who talks and tries to manage epidurals post-op, fluid doesn't help to mitigate epidural-induced hypotension. Only alpha agents do. As long as you're normovolemic, which is the premise, obviously, after elective surgery, you should be. So this illustrates here what happens. We live on the top, right? So about a third of our blood volume actually circulates. The rest sits in the splanchnic system, and it's called unstressed volume, or whatever you want to call it. If you bleed, yeah, you lose both, and then you should refill the tank. But if you have anesthesia, and if you have an epidural, or you're septic, your tank widens. And filling that tank actually would overload you. No, what you do is you tone up the tank again, so you go back to the top level. And of course, there are situations where both is true, which doesn't necessarily apply to the general case. So an empty IVC in the hyperkinetic heart doesn't always mean you're hypovolemic. And what you assess at the bedside, whether it's with ultrasound or other devices, needs to be combined with your understanding of physiology. What pressors do is also not trivial, because this paper shows very nicely that phenylephrine may do a lot of things on your cardiac output. It may increase it, it may do nothing to it, or it may decrease it, and it depends on where your patient is on the Starling curve and whether your patient is volume responsive or not. Because as an alpha agent, phenylephrine mostly does what? It's a venotone increaser, basically, especially at lower doses. So if you don't look, you're not going to see it. And then last but not least, yet another factor that complicates, and that's propofol, which may actually increase or worsen diastolic dysfunction. And there was just an abstract presented at the Society of Cardiac Anesthesiology meeting. So yet another complicating factor. So it's complicated. And you won't get off the hook that easily, because when you speed and you get caught and you say, well, I wasn't looking at flow, so my speedometer wasn't working, then you may actually get fined not only for speeding, but also for operating with faulty equipment. And when you fly home tonight, would you trust the pilot who covers up half of his instruments because he says he can make enough inferences from just looking at blood pressure and heart rate and ignore flow altogether? So why not measure flow? And in the interest of time, I'm actually going to skip this, because we will talk about that in a minute, probably a lot better than I can here. But I do not want to leave you without talking about the second commencement speech that I really love, and that is David Foster Wallace at Kenyon College 2005. It is unimaginably hard to do this, to stay conscious and alive in the adult world day in, day out, which means yet another grand cliche turns out to be true. Your education really is a job of a lifetime, and it commences now. So practice deliberately, be an expert, don't be satisfied with just make it past the sucks threshold and not be an amateur. Fluids are drugs, they have indications, contraindications, side effects, don't give it when risk outweighs benefit. A fluid challenge is a treatment and not a diagnostic test, and lack of volume responsiveness is a marker to start removal of fluid. Thank you. My email if you have any questions, and I'm looking forward to a great debate.
Thanks, Matthias. Next we've got Brenton French. Just so you know, he's actually a surgeon who was one of my quality improvement fellows down in VCU. And he's done 2 years' work on all sorts of things about hemodynamics, AKI, emergency laparotomy, and this is some of the work that he did on long-term effects of hemodynamics and AKI, and he's going to give us an overview of this. Thank you very much. Thanks.
All right, Dr. Scott forgot to mention that I'm still a resident, though. So my name is Brenton French. Again, I'm a third-year general surgery resident at VCU Health System in Richmond, Virginia. And I'm going to discuss a little bit about perioperative acute kidney injury, its relationship to surgical outcomes, and some interesting data we got from our own institution on this topic. So a few acknowledgments. I do have to thank Dr. Scott as my faculty mentor for all my research, and I'd be remiss if I did not thank Dr. Pranav Shah in the Department of Anesthesia at VCU. He was very instrumental in developing our data collection instruments and in our GDHT program implementation as well. So A couple things to start with. So kind of how do we get interested in this in the first place? And why do we focus so much on AKI? Well, for one, it's really easy to track. So if you look at it just from a practicality standpoint, most patients who are having major surgery or major abdominal operation will have some sort of baseline creatinine, and some of them will have a postoperative creatinine. More rare complications, hemorrhage, pneumonia, take back to the OR, a bit harder to track, but this is a pretty good marker of perfusion, and it's really easy for us to look at thousands of patients with data points and see kind of where the prevalence is and where our problem areas are. So, of course, there's always limitations to AKI, but creatinine may not be the best marker, kind of as we'll discuss in a little bit. There's cystatin C, NGAL, and others, but essentially, if we consider AKI a marker of organ dysfunction, it's kind of interrelated with various complications, and kind of we'll walk through that process here. So first, though, we do have to recap the definitions. This is a little bit tedious, but we do use KDIGO in current research. The rifle criteria was older, similar to KDIGO, but with some differences. And then the NSQIP definition, so a NSQIP definition of renal failure is a 2 milligram per deciliter increase in creatinine from the baseline or initiation of renal replacement therapy. So NSQIP renal failure basically picks up stage 3 AKI in the KDIGO system. So moral of this is for a stage 1 AKI, it's a 0.3 milligram per deciliter increase in baseline, or 50%, whichever is less. So to kind of go for kind of a quick overview of what's already been published on this topic, a good example of the impact of AKI was shown in a 2015 study at the University of Florida. They looked at 50,000 major surgical patients over 10 years. They used the rifle criteria for AKI, and they found that patients with AKI had an 8.8% rate of in-hospital mortality compared to a 0.6% rate for those without AKI. 90-day mortality was 11.3% versus 2.2% in the no AKI group, so a significant increase. Of course, a big limitation was they kind of lumped in all emergent and elective cases into this. They included cardiac surgical patients, which a lot of modern studies, they look at those separately. So they got a high overall rate of AKI, and a lot of this was pre-ERAS prevalent data as well. But what they did do that we found pretty valuable was they looked at the costs. So if you're interested in saving money, kind of this is where we should look. And they found that, they found that patients with any AKI had a risk-adjusted 60% increase in hospital costs, which ended up as nearly $16,000 of additional cost per patient. And then if you met the renal failure definition, so most of these are patients going on dialysis, $40,000 of additional hospital costs if you go on dialysis. So there's a signal towards worse short-term outcomes and higher costs in surgical patients, which would make sense with this basically, but what about longer-term outcomes? So this 2017 study in the British Journal of Surgery gave some preliminary data on that. So they looked at over 1,800 patients undergoing major non-cardiac surgery, elective cases only, so a bit of a more defined population. They identified 128 patients with AKI, which is kind of closer to the incidence rate at our institution, and their primary endpoint was 1-year mortality. And so when comparing patients with any AKI to those without AKI, again, they found a significantly higher rate of in-hospital mortality, but they found that 26% of patients with AKI had died by 1 year after surgery compared to 6% of patients without AKI. And the adjusted hazard ratio they got was 3 for this. So again, their survival curve is illustrated here. So interesting finding, but it's a pretty high mortality rate, and I think it's explained by the fact that they lumped patients going on dialysis in with patients who just had like a stage 1 AKI as well. But still, the difference in long-term outcomes was pretty significant. So some limitations in some of this data. So at VCU, we tried to figure out how could we kind of more properly define our population, use the modern definitions, and then what about like these stage 1 AKIs? Like, does a stage 1 AKI actually affect your long-term outcomes in any way? So So what we did is we looked at all elective non-cardiac surgery cases over about 4 years, and endpoints were in-hospital mortality, 1-year mortality, length of stay, and cost of the surgical hospitalization. So all patients had a length of stay of greater than a day. They had to have a creatinine within 30 days prior to surgery, so it's kind of a more accurate reflection of the true change in renal function. And we excluded any urologic procedures or organ transplants. So all of our 1-year mortality data was from VCU, along with the Social Security Death Master File and the Virginia Department of Health to identify anyone who happened to die outside of our health system. So, and these were our results. So we found about 9,000 patients. We found an AKI rate overall of 7.3%, and 80% of all the AKIs were stage 1. And AKI was strongly associated with all outcomes studied, essentially. So looking at inpatient mortality, you can see that stepwise, you can see a stepwise increase based on the stage of AKI. So if you look at stage 1, it's associated with 13.9% rate of 1-year mortality compared to a 5.2% rate for those without AKI. And 1-year mortality increases to 19% and 23% for stage 2 and stage 3. And you can also see a stepwise increase in mean hospital costs over on the right side of the screen there. So $20,000 mean cost for no AKI, up to $73,000 for patients who go on to need dialysis for mean total costs of the surgical hospitalization. So, and this was a unadjusted survival curve, again, unadjusted, so it just kind of gives an overview. But you can see that patients with all stages of AKI below the green line is patients without AKI, have a higher likelihood of 1-year mortality. There's also this pattern of patients who go on dialysis dying sooner that you can see by that steep decline in the black line there. But if we move into our multivariate analysis, that's shown here, displays all the adjusted odds ratios for mortality and linear regression estimates for cost and length of stay. So this is all adjusted for case and procedure factors at this point. And you can see that AKI is still associated with a 2, 2.5, and 10 additional days in the hospital based on stage 1, 2, and 3 versus patients without AKI. They're twice as likely, or patients with stage 1 AKI, twice as likely to die at 1 year compared to those without AKI. And for the cost data, again, this is the adjusted additional costs associated with AKI. A stage 1 AKI we found was associated with over $4,000 of additional hospital costs, $41,000 if you went on to need dialysis. So that's the additional cost that's applied if you have an AKI compared to patients without AKI. So, what can we take away from this? Kind of our hypothesis is that AKI is a marker of physiologic insult or inadequate organ perfusion, and we know it's related to multiple postoperative complications. So like if a patient gets a partial colectomy, they get an anastomotic leak, then they probably get an AKI. Same for excessive blood loss or return to the OR, much higher risk of getting AKI just due to that association with other complications. So essentially we've shown there's a higher risk of adverse outcomes in patients with AKI, but maybe more of an association with longer length of stay, higher costs, and higher mortality. Kind of a bold statement. This was actually from one of our nephrologists, Imran Fatani, who said the data suggests that there's no such thing as a minor AKI in this setting. But I think what this highlights is a population that needs more attention and focus. You know, can I say that a stage 1 AKI dramatically increases your risk of 1-year mortality? I can't really say that with retrospective data, but I can tell you that there's definitely an association. And we need kind of more focused efforts to reduce AKI, or rather, I think, the underlying physiologic dysfunction that it represents. So with that, I'm going to hand over to Dr. Scott, who's going to continue on that topic.
Thanks, Brenton. So it's interesting. I think it's the first work that's shown that, you know, just a mild AKI, stage 1 AKI that most people ignore has a downstream effect at 1 year, as well as a cost impact, if you think it's quite profound. So really the kidney seems to be the canary in the coal mine, doesn't it, of basically tissue hypoperfusion. And that's what I'm going to talk about now, really, comprehensive hemodynamic management. We've done this back in my institute in Guildford back in the UK since 2003, where every single patient having major surgery had some sort of flow monitoring and went to a high-level care area. And it's one of the reasons we still believe we had such good low complication rates and good cancer outcomes. And this is the similar framework, and I'm trying to give you the recent evidence to support this, which is basically fill flow pressure. Fill the tank, make sure there's enough flow, and then squeeze. Those are my disclosures. There are a lot of relevant disclosures because this is one of my areas of research and interest. So in Perioperative Medicine, the big textbook that came out this year, I wrote the chapter, and this is really, I think, the 4 components of perioperative hemodynamic management. It's not just fluid, it's perfusion with pressure, but also you need enough flow and enough hemoglobin carrying enough oxygen. And really, it's just about perfusion and oxygen delivery. That's what your body needs. And we do it very badly during surgery because you've got all these drugs that vasodilate you. And during surgery itself, you're under intermittent positive pressure ventilation. And those are really the 2 things that impact the body during surgery. So I'm going to talk about these 4 papers just briefly to give you the reason why I still believe this framework is good. Just to back up the data between AKI and hypotension, there's this landmark paper really now from anesthesiology 2017 from the Cleveland Clinic with Andrea Kurtz, Dan Sessler, with Salmazi as the first author. Big data, 57,000 patients, looking at post-op AKI and MINS, myocardial injury. And really what they showed was the lower your blood pressure and the longer you go below that blood pressure, the bigger the harm. I think that's really simply I want the message to take away. And we know that a MAP of 65 is becoming the hard deck. And we do know that MAPs below 60 are particularly harmful. There's this other review on hypotension by Veselink's group, which was a systematic review in the BJA. It looked at basically hypotension in non-cardiac surgery, which I think is important, 42 articles, and then they looked at the blood pressures. And what I really like about this is they gave us a heat map. What's good, what's bad. And you can see this really supports, again, that you can see that the maps are on the left, going from 40 up to 80. We hope no one really has 40 or 45 or 50. But you can see there's definitely this hard deck at 65 above, which you seem to be okay. But the lower you go and the longer you go, the more likely you are going to get either mortality, AKI, myocardial injury, or other overall organ injury. Interestingly, stroke is not a risk there, which is interesting. So, can we forget about doing this in young patients? No, we can't. So I just picked this paper, really, to show that AKI occurred in almost 4% of non-cardiac surgery patients who were relatively young with low comorbidities. And what they showed, again, was if a low MAP for greater than 20 minutes increased your odds ratio of AKI by up to 14. So again, the kidney's a very pressure and flow dependent organ. So if you think of this, why are we flying our plane across the treetops? Why don't we just give ourselves a little bit of headroom? And yet you go into any OR and we're always just flying along the tree line with our blood pressures, aren't we? So the relief study by Paul Miles's group has really given us very useful information, I think. So this was a multi-center, multinational study, 3,000 patients, and this idea of restrictive or liberal. Now that, as Matthias says, is really the concept of restrictive has changed. Previous restrictive definitions in the early 2000s is really what a liberal regime is now. But really what the aim was we were trying to land people on a body weight of zero balance, almost no kilogram gain in weight, or we're going to allow them to have a little bit of a positive fluid balance of 1 to 2 kilos. That's really what this is about. And it was a very well conducted study. The median intravenous fluid intake in the restrictive group was 3.7 litres compared with 6 litres in the liberal group. And basically the main signal was the disability-free survival at 1 year was not much different, but there was a signal of harm in the restrictive group for mild AKI. And just to drill down to give you numbers, you can see here we've got restrictive on the left, liberal on the right. crystalloid 1,677 mils versus 3,000, colloid about the same. Post-operative day 1, which I think is important, again, it just showed that the liberal group was ahead, as expected, by 6 litres versus 3.6 litres. But what's really important about this study is they did what they set out to do. So the restricted fluid group just landed 0.3 kilograms above their starting weight. So if you think by the time you have a bit of something chopped out your body, that's pretty good. The liberal group were 1.6 kilos, which is about 20 mils per kilo above your above your dry weight, sorry. And really, there was no real differences apart from this mild signal of AKI. But to summarize that, this is what's important, is the fluid balance at the end of 24 hours, because this suddenly gives us a fluid zone to land our patients in, because we know that a sort of roughly even balance, you might get a mild AKI, but we know 20 mils per kilo is okay, if not slightly better, which makes sense because you've got these, stress and slight edema of your tissues, and then obviously, as we all know, then the patients pee that out over the next couple of days. So my interpretation of this study is zero balance might not really necessarily increase you for AKI, because one of the problems of the study is that some of the patients got a 750 to 1 litre loading, and they might have been dehydrated because not all of them got their oral carbohydrate drinks. But the key thing is the zoning here, that up to 20 mils per kilo is a safe zone. So I just now want to show you 2 studies which did what we did in Guildford, fill flow pressure. And I'm going to do this quite quickly, but this is the IMPRESS study in JAMA, again, landmark study. And they basically measured flow. They then used low-dose norepinephrine to maintain MAPS above 65. You can see the difference between the standard and the individualized treatment group. We're only talking between 5 to 8 millimeters of blood pressure. But what was amazing is when you looked at the Kaplan-Meier estimates of the probability of post-operative organ dysfunction by day 30, there was a big impact if you actually got your blood pressure just squeezed slightly higher. But this is after fixing flow. This is the Fedora study, which did the same thing. They fixed flow, then they used their pressors. So fill, flow, pressure. The algorithm that you sort of are familiar with, but this time it's start of a low-dose vasopressor. And all we're doing is overcoming the effects of anesthesia drugs. And they showed that there was a big impact in AKI, reduction in, which goes along with better perfusion, and also because you're not throwing lots and lots of fluid at a baggy circulation, you don't get the effects of the fluid overload, the ARDS and the pneumonias. But also, you got better reduction in infection parameters. And we think that's probably because you're perfusing the gut better. But the key thing about this study is it gets back to what I've been saying for the last 20 years. It's not the amount of fluid that always matters. It's the timing of the fluid and maintaining optimal flow and perfusion throughout the perioperative period. So this is published in Perioperative Medicine as well. So this is what I sort of configured, this green zone of where we need to land our patients, which is above euvolemia, but not more than about 20 mils per kilo. And you can see that the black line is traditional surgery, and we come in the preoperative phase dehydrated with bowel prep, and you've got that increased risk of splanchnic hypoperfusion because you then induce anesthesia and the patient crashes, and then you've got to catch up with your fluid. But then post-operatively, by day 1, day 2, we normally overload our patients with abnormal saline, don't we? So then they get a bit of fluid overload and ileus. So the whole point of ERAS is that we just keep people in this green zone of maintaining flow and maintaining pressure. And so the reason why I think recent GDFT studies have not been significant is ERAS has made fluid a lot easier for anesthesia. Everyone arrives hydrated now, and we get down all this fluid overload because we get people eating, drinking early in the post-operative period by day 1. So really, we've now only got to think about the bit in the middle, which is the perioperative flow measurement. But what we do know is that the significant GDFT studies still are in those patients with comorbidities, prolonged surgery, or with large fluid shifts or blood loss. And obviously, you've also got to include emergency general surgery in there. So that's the bit in the middle that deserves the flow monitoring most. So I think, hopefully I've just given you the evidence to support the structure that we need to maintain optimal intravascular volume, avoiding both hypo and hypervolemia. Timing of fluid is as important as total quantity. We now have a hard deck we shouldn't go below, which is a MAPA 65, and we know low-dose vasopressors don't harm, they improve. We should be using flow-directed monitoring in those high-risk patients or high-risk surgery with high blood loss situations. We know that if we land our patients 10 to 30 mils per kilo over admission weight, we're going to be okay. And if we avoid that salt and water overload, then we should be landing most patients in that zone okay. And I think this review by Tim Miller and Paul Miles after relief was very good, because you can see here, if you've got, at the bottom axis is a patient risk and on the left is surgical risk. If you've just got a quick 1 to 2 hour major surgery with a fit patient, we know that we're going to land most people in that zone. So you don't need some sort of flow monitoring. However, if you increase surgical risk or you increase patient risk, or you have both, then you need to look at flow monitoring, and certainly high risk, high patient, you should be going to the ICU for post-operative optimization. So when you look at this, really, to give you a sort of 3D map, what I think is important is we give our volume at the start of induction of anesthesia. We then give our background, this is for laparoscopic surgery, with targeted boluses, and then once you're transition from PACU to the floor, you go on to oral fluids. And the difference with open surgery is you've got a higher background rate and you're just giving a few more boluses. So I hope I've given you a framework. We're actually going to take questions at the end, if that's all right. We've decided just so that we can present a lot more of the evidence. So thank you for listening. And then I'm now going to hand over to Brenton, who's going to show what we did in the Virginia Commonwealth of how do you actually do this? Because a lot of people say they do goal-directed fluid therapy, but what are we actually doing? So thank you, Brenton. I'll wait here.
All right. So thank you to Dr. Scott. So now back to talk about implementation. So we had some success recently with implementing a GDHT protocol within our ERAS program for major colorectal surgery at VCU. So I'm going to discuss this as kind of how this can be an example of this can be implemented. In the first abstract session, I talked about our results. So we were able to reduce AKI by 55% in major elective colorectal surgery patients. But this is now more about how we implemented it into our program and how we got providers to start using it as part of ERAS. So we've seen that GDHT can reduce complications, we've read the papers, but now what? So how do you take these findings and start actually making it part of your day-to-day clinical practice? How do you go through getting the cardiac output monitors onto the patients in the OR and getting the providers to actually kind of follow your protocol? And additionally, how do you do this at a very busy academic urban medical center with a huge number of anesthesiologists and perioperative faculty? How do you get everyone on the same page for something like this? So to start, we had an ERAS project team, or we still do. It was headed by Dr. Scott, and so we kind of formulated our plan within this group. So this is like anesthesiologists, it's attending surgeons, nursing staff, and various administrators as well. So this was kind of the core group where we made the plan that we're going to implement goal-directed hemodynamic therapy in the ORs for high-risk surgical cases. We're going to start with colorectal as like a pilot program to kind of get a success story, so we can hopefully take it to other specialties. And how this started was, we started with a preliminary discussion document. So what this is basically a mini review article that Dr. Scott and I wrote to circulate internally to our various division chairs and people on our perioperative executive committee. So this is kind of the preliminary plan, and then we circulate it to the key leadership on the committee that kind of approves perioperative protocols and practices and kind of moderates all of this for the ORs and the surgical services. So we present our proposal for a GDHT program to this board. We email them all this discussion document, and then we ask for feedback or ask for changes. And then when all this is complete, we have quality standards at VCU that basically say, like, this is our position on how these patients should be managed. Saying that major elective surgeries will be encouraged to use goal-directed hemodynamic therapy in the OR for hemodynamic management. And so while kind of tedious, this does give you administrative backing for this sort of thing and for your efforts. And so it also gives us, funding to buy the cardiac output monitors and things along those lines as well. So an interesting kind of use for data for something like this was a question came up, like, how do you know that with your intention to reduce AKI, how do you know that AKI is occurring in and around surgery? So we have a pretty powerful perioperative data system that's able to extract all data from our EMR of our surgical patients. So, basically, how do you know that AKIs are occurring in and around surgery, and not because the patient's getting C. diff on post-op day 4, has a high output ileostomy on post-op day 3, or something like that. So we were able to use our data system to answer that question. We were able to pull 1,000 cases of AKI from our major non-cardiac surgery cases, and we could see that 64% of patients with AKI had a peak creatinine within 2 days of surgery, and 77% had it within 3 days of surgery. So, and it looks like 20% occurred after post-op day 3, so that may be due to some other complication or infection that comes up. But this is kind of confirming something we already knew. But again, it's important to kind of have that data to be able to show, that you definitively know where your problem is. So with that, in August of 2019, we had finalized our GDHT protocol, and we got an approval from our administrators. And basically, the point of this whole protocol, and I discussed this a bit on Wednesday, the point was to maintain a target stroke volume during surgery. So like when the patient gets to the OR, we either do a Trendelenburg test, we do a passive leg raise test, or a 250 cc fluid bolus, and we see where they're at. We don't give them fluid continuously until their stroke volume is maximized. It's more kind of like an optimization versus a maximization sort of thing. So once we identify the target stroke volume, the goal is basically just to maintain that stroke volume during the case. If something changes, but the patient's not fluid responsive, then you kind of set your new target stroke volume, but consider like reasons why that may have changed. So this was basically, one other thing to figure out was how exactly would you determine which cases are going to get these fluid monitors in the OR? Like, it sounds pretty complicated. How would the provider know like which cases they needed to do this for? So with that, we also developed intraoperative ERAS anesthesia pathways, and again, this is the pathway for colorectal surgery. So what this is basically if you know you have a colorectal surgery case, it's a major abdominal case, this gives you a guide to analgesia recommendations, PONV prophylaxis, preferred antibiotics, and recommended DVT prophylaxis for each case type. So in discussing with our colorectal surgeons, there's 3 main abdominal colorectal surgery case types that they had. So they basically space this out by laparoscopic or minimally invasive bowel surgery, open bowel surgery, and then loop ileostomy closure, because loop ileostomy closures are typically 45-minute cases. They're not these long 3-hour bowel surgery cases, so they kind of wanted to manage those a little bit differently. So the anesthesia provider will have this plan, and again, with colorectal, if the patient comes in for a laparoscopic sigmoid colectomy, they can see that it's a minimally invasive bowel surgery, and then they go down to the fluid plan, and the fluid plan basically says use GDHT for this case, and then they know to use the GDHT protocol, which I'd shown you in the other slide. So that's kind of how this all works. But if you're doing a loop ileostomy closure, you don't need to, because again, quick case, we didn't feel like the resource allocation would be appropriate for shorter cases like that. So. And then here are some of the devices we used in the OR. We have the esophageal Doppler if the patient was getting an arterial line. So again, in colorectal surgery, that's mainly like an APR, a bit rare to have an A line for this in more of the more routine cases. But if you had it, you could use the flow track. And then a lot of our providers like the bioreactance pad system, just because it was easy. We could get the anesthesia techs to place the pads out in the pre-op area so they could just come back to the OR and be hooked up to the monitor. So to kind of get this started, again, using colorectal as the pilot group, I was usually in the OR each day kind of showing providers the protocol. I got really good at troubleshooting the machines. I had all the rep phone numbers about how to fix them if they broke. But the effective thing I think that we had was we had an anesthesia champion for each sort of intraoperative protocol. So for us, that was Dr. Aaron Lim at VCU. He was basically an anesthesiologist who took ownership of the intraoperative plan, the intraoperative pathway. They could change it if they noticed issues with it, and they usually ended up doing a lot of the cases with the attendings, so they got used to the protocol, used to the fluid plan, so we kind of had some continuity in providers for these cases as well. So once this was up and running, we were able to get compliance up to 81% with the program, and then we were able to demonstrate that 55% reduction in the rate of AKI. So the reason we were able to do that, though, is we had this perioperative data system that was able to identify who was and who wasn't using the cardiac output monitoring. And so the data, again, basically extracts everything from our EMR records of our surgical patients, which was a whole separate project of mine. But the provider has to chart what device they're using during surgery, so we can basically see if they're using it or if they're not. So, and then we were able to track our outcomes, track the big reduction in AKI, and then once we had that, we kind of had a success story. So I did it once we were able to demonstrate that improvement. I was able to go to give a grand rounds for our surgical department, and then once I was able to show that, hey, the colorectal surgeons have reduced their AKIs by 55%, the surgical oncologists, the ventral hernia specialists, all were very interested at that point. So it was very good. So again, basically with our data system, we could track our complications. This kind of allowed us to see how we were doing. We could identify patients with stage 2, stage 3 AKI, do chart reviews, figure out what happens to try to continually improve this program. So in summary, we were able to implement this complex intraoperative hemodynamic management plan, get compliance of over 80%, and the key steps we did were to, 1, develop your plan, 2, get administrative backing, make it practical. So these case guides were actually really useful for our anesthesia residents and trainees, because if they weren't familiar with ERAS or colorectal surgeries, they could come in and they could see what we kind of considered standard practice for these procedure types. So they were actually really big fans of these intraoperative protocols. But it literally spells out kind of everything you have to do for the patient. Track your compliance, track your outcomes, and then when you have a success, advertise it, because that will kind of continue with compliance and possibly spread it to other services as well. So that's what I have. Thank you very much.
Thanks, Brenton. We're going to open up the discussion, but I'd like Tonya to come on the stage to represent the surgeons. I think you can see what an amazing piece of work that Brenton's done in just 2 years. And it's great to have a surgeon champion, the hemodynamics as well. It's really raised all surgeons' awareness, and I think you can see having a framework that's agreed on by all parties. But I think the fascinating thing is there's been argument over stroke volume maximization to the top of the Starling curve, but we know that that can be harmful in fit compliant ventricles. So you can see all we did was basically put the monitors on and do a passive leg raise or a Trendelenburg, which is what we used to do in Guildford. And all we're doing is we're not giving people a heart transplant by super maximizing their stroke volume. We're just making sure that they're not relatively hypovolemic after the induction of anesthesia and with positive pressure ventilation, because that's what creates all your different spaces and shifts. So what we're doing is just basically starting with the patient in the middle of the road before we start surgery. And at the end, we do the same thing. So really, it's a 2-point optimization, very straightforward. And you could see we literally dissolved AKI away. And I think there's a hard deck of AKI, because even in Guildford, we had 2% AKI in major surgery. I think that's sort of the bottom that you can go. But in VCU, our patient population was a lot sicker than we had in Guildford. So I think Brenton's work has probably taken AKI to one of the lowest levels for the perioperative bit. But he did mention that we've got a secondary bump at about day 5, which is probably related more to post-operative perfusion and sepsis. So I'd like to start taking, please do come up and ask questions. So we hope we've given you the why and also a bit of the how. And what you can do in your own institute. Would anyone like to follow any questions for the panel?
Yes, thank you so much for that, for those talks. They are amazing. I have a question why you chose stroke volume, and maybe I'm revealing my lack of understanding. I thought cardiac output was what we're really interested in, and most of the algorithms have either cardiac output or stroke volume variation, and stroke volume variation obviously has its own problems where you can chase that into an overload situation, but what made you choose stroke volume rather than cardiac output?
I think it's purely because of the fact that you want to optimize that stroke volume to that patient to get them back to their baseline. And that's what we're doing. As I say, it's not aggressive stroke volume maximization. If we put the monitor on and then we do a passive leg raise or go head down and the stroke volume goes up, we give a little fluid bolus until we do that. And really, you can see we were trying to be monitor agnostic, because different people like different monitors. Not everyone gets an arterial line. So we were trying to make sure that we could do this across all specialties. And what we really, it sounds really funny what I'm about to say, but really the monitors can just have the number of bananas that patient's stroke volume is. Because if the patient starts with 19 bananas on the monitor, and you induce anesthesia and they go down to 16 bananas, then you give them a bit more fluid till they're back to 19 bananas. And when we sort of introduce this concept that the actual thing, everyone's fascinated with the exact stroke volume. There's, and that study showed it's 8% out. It really doesn't matter. All these monitors reflect change in stroke volume and flow. And they have a good sweet spot for that. So all we're doing is using a flow-based device to get the patient back in the middle of the road where they should be. And then and that was our target for the surgery, just to keep them in the middle of the road. So we weren't doing anything really clever here, and yet we dissolved AKI away. So I think what you're doing is you're just through the perioperative period, you're just stopping those 20 minutes of relative hypoperfusion for the kidneys. But hopefully also Brenton's work showing is that if you're reducing we got rid of stage 2-3 AKI very quickly by using the monitors. But what was interesting is we actually made a big impact to stage 1 AKI as well. And when you link stage 1 AKI and outcome now, you think you could be doing a lot of good for your patient downstream. So it's only subtle changes, but they seem to have a big downstream impact. And the big problem, I think, in the world of anesthesia and for CRNAs and for myself as an attending, is it's hard to show your colleagues in the OR that you're actually making a difference, because they can't tell the difference in the patient in the PACU. And we even showed, some of the studies showed no difference in total quantity. So you think, oh, I've given my 2.5 litres, I've done it okay, but it's the timing that's important. So one of the most important things that Brenton showed was the feedback, that every month we send a PDF out with all the quality indicators that we map on Tableau, individualized. People can look at their individual outcomes, but they've seen the effects and the AKI dissolve away. So suddenly you've got your whole team in your department think, oh, well, we're actually doing a good job. So that's a long answer, but it's a 3-year project.
I'm sorry, you did the passive leg raise in the operating room before?
Yeah, you do PLR, or you just put the head down, the operating room table, head down. If the stroke volume doesn't change, that patient has got no more recruitable stroke volume, and that's the difference. So we're not giving fluid boluses chasing them up. We're literally just we're just stopping bad things from happening. We're just stopping occult hypovolemia, which is interesting. So it is a different approach, and it worked.
May I ask how you operationalized it? So you did it at the timeout, or how did you actually?
I'm going to let Brenton do that.
It was usually right after induction. So conveniently, if you're doing lithotomy position for colorectal surgery, you could do the passive leg raise like right before you put them into like the full lithotomy position. If you had missed it, you would do you could do the Trendelenburg challenge as well. So if you were already in lithotomy, like had forgotten or something, you could basically tilt them, and then last option is you could just give a 250 cc fluid bolus. But typically, you would do your timeout. You would, you would have anesthesia induced. You would do your timeout, and then we would do the maneuvers at that point, and then right before all the surgical prep and everything started. So.
Another opportunity in laparoscopic cases, because we frequently use steep inclines in pressure, Before we drape the patient, we do a tilt test to all four corners of the table in both Trendelenburg and reverse Trendelenburg, right and left, so all four cardinal positions, if you like, and that's an opportune time for doing it.
That's great.
And then I wanted to add, stroke volume variation is probably a measure that is too imprecise to be useful, because if you look at any given paper, people are volume responsive in 50% of the cases, and that awfully looks like a coin toss to me. So it's more than that, right? So if you do what's presented here, and you have this continuous feedback loop of flow, pressure, and squeeze, you will even find that situation where the patient is so vasodilated that the patient is falsely not volume responsive because the fluid you give goes into the unstressed pool. But if your pressure is low, you start a vasopressor and you start your next cycle of testing volume responsiveness, suddenly your patient does become volume responsive. And that's a situation that is rare, and I only see that in emergency laparotomy situations. That is not your elective case. I think really this month is, and it's beautiful how Mike Scott brought this on into the world, basically, right? Flow, pressure, squeeze, repeat. And I would add, keep your mind engaged, because your beautifully, highly educated mind is still important. And you can call this consider physiology, wherever you do it. Can this be, right? So have this debate with you ongoing. Can this be what you see?
I think my worry at the moment is we've gone through this point where, I mean, you know, when you go back to the UK work, which was standardized, published, Carroll, I mean, our results out of Guildford were, you know, just so far ahead of everything, and then everyone caught up as we introduced DRAS and all these other things. I think my worry is the last few studies of GDFT, and again, we want to start calling it hemodynamic therapy, not fluid therapy, because it's everything. It's flow, it's pressure, it's hemoglobin and oxygen carrying capacity. Everyone's saying, oh, we don't need to do it now, and yet every day I look at my patient population, and even for slight sort of moderate patients now, you know, my last two patients, I had one who'd been on ECMO for 2 weeks with RV dysfunction, and they were coming in for a quick abdominal procedure, but they already had kidney failure. And so everyone's saying, well, why are you getting the monitors out? Well, you're making a difference to that patient. And the other patient who's, you know, and again, end-stage renal with heart problems, well, you might not make a difference on the kidney, but you might make a difference on the heart, because we know that MINS is actually just as important. So my worry is that in the medicine we're working, we're operating on so many sick people now, it's even more reason to get all these monitors out. And yet everyone's using an excuse that, oh, well, that one paper of 100 people didn't show a difference. So there's a whole sort of community engagement we need. And it is interesting because it's like there is politics in it. I mean, you know, anesthesiology, any excuse not to show that this doesn't work, they come out with an editorial, oh, it doesn't work. They've done that twice. And it just depends who's sitting in that editorial seat. So we all have to be very aware of just capturing the headline and not looking at the real science.
Hi, I just want to thank you guys so much. What a great presentation. I'm an anesthesiologist, private practice, community, small-based hospital, and actually am from New Orleans, but I actually live in Lafayette, and I find it very interesting that I'm the only one from this, you know, from Louisiana maybe that's here. But my question is, how do you take this information and try to apply it to a smaller facility? You know, I come from a bigger place, and we had access to all those monitors, but obviously where I am, I don't have access to those monitors. So how do you approach this in a place where maybe you don't have all the data? And also for ambulatory patients that are going home that you can't necessarily follow labs. So any thoughts or any help in how I could do better and hopefully bring that back to my practice?
Well, I'll come with a bit and then I'll let Brenton do the implementation bit. I think for day case surgery, there's really no evidence out there. They shouldn't be going home if they're at risk of AKI. So I think that you wouldn't need to worry about. That's just sensible volume zoning. So hopefully I showed that preload gets you in the middle of the road in that zone, and then you've got surgery, and then you've got the meeting and drinking anyway, haven't you? So you've just got to make sure that you give some volume before positive pressure ventilation, which is, in the UK we mapped at 8 to 15 mils per kilo, so that's why 750 a litre, like in Relief study, worked. And that helps with that sort of volume changes. Then sensible amount during surgery. So I don't think you need it for that. But for major surgery, I think you've got to go back to where's your risk, look at your data set, where are your patients that are coming to harm, then look at the business case, put it all together. We use discussion documents in the UK as a way of getting this information across. It's something I brought to the US. So when Carol and I were national clinical advisors, everyone meet in London and you say, right, well, this is the problem, this is the evidence, this is how we're going to fix it. And it went out nationally, and this is what we're going to do. So that's what we did at VCU, and we made it a quality indicator so people couldn't duck out of it and say, oh, it doesn't affect me. So that's the sort of sequence. But you do need data. So, I mean, we spent $500,000 creating that Tableau data set, and I had to go to the executive body. But by that time, we got buy-in because we'd almost dissolved SSI away. So they knew it all was working. So then they bought in, and then we've got this amazing system that just gives you real-time compliance and outcomes. Mm-hmm. So it's hard work, and you probably need some people to go with you and try and get some surgical champions and some anaesthesia champions, and then get together and then sell it to your own department and the CRNAs, and put quality first. What would you suggest, Brenton?
Right, and honestly, there may even be a benefit to having a smaller group. If you know exactly who's going to be doing each case, rather, because at our institution having over 50 anesthesia faculty, I mentioned that having one anesthesiologist kind of in charge of that pathway and doing a lot of the cases and getting familiar with the surgeons and familiar with the protocol was actually super beneficial. So that may be replicable at a smaller institution, but it was very helpful to have the data. We had also shown our surgical departments, we knew that renal failure had been an issue from our NSQIP data for a long time as well. This is something I wasn't able to show, but we knew that we were persistently struggling with renal failure rates, and so there have been several initiatives to get things done. So I don't know if there's any sort of national, or if you have access to any of the NSQIP data sets, or the surgeons do, but that can kind of help if you don't have a freely available Tableau system like we had developed and everything. But a lot of times they'll have some Vizient data or some NSQIP data that can kind of help show you renal failure rates, pneumonia rates, things like that.
You're absolutely right, Brenton. The big problem I think Brenton highlighted is NSQIP only talks about renal failure when your creatinine is greater than 2.
Right.
So you're missing a load of the problem, which is why we then actually mapped the problem before we started. So that it's very involved. But I do think the kidney's the canary in the coal mine of low body perfusion during the perioperative period, and it's easy to map. But we know the downstream effects of all-cause hypoperfusion and complications are a downstream life expectancy effect, and that's been shown in all types of complications. And we're also seeing it from a oncological perspective, that you get a worse, either cancer-free or disease-free cancer state. You're much more likely to get recurrence of cancer if you have a complication.
Can I ask how many surgeons are in the audience? Fantastic. It really is important that you partner with your anesthesia champions on this, because unlike Las Vegas, what happens in the OR doesn't stay in the OR. It comes back and plagues you as the surgeon in the post-op period. So as you can see here, if they're under-resuscitated in the OR, you're dealing with AKI. If the patient is flooded with fluid, you or your team are getting called for atrial fibrillation on post-op day 3 if the patient's still here, or they're going into AFib at home. So it's really important that you have that communication across the blood-brain barrier.
The other really interesting thing that we've had feedback from surgeons, Jamie Boll, who's been the colorectal lead, is that obviously we halved opioids by introducing regional analgesia and multimodal. But we've gone to a higher level because she said she's now so confident of giving non-steroidals to patients because she knows that they're not going to get renal dysfunction due to volume or pressure effects. So she's introduced non-steroidals much earlier, or even in the OR, which again has had a massive effect on opioids and again downstream length of stay. So this is not just about organ perfusion, it can help guide your analgesia.
And the barrier for getting one of these monitors in your even community institution might be smaller than you think it is, because the cost for any of these devices is a fraction of what it costs to stay an additional day or stay for the complication. And if you're limited to really your complex cases where they have shown unequivocally the benefit, it should be doable to make that case to the C-suite.
And I have to be neutral because I work with all the different companies. I'm a believer in just measuring flow, but there's non-invasive cuffs coming out now which can be integrated instead of A-lines. So you can have one monitor, and it means that if your surgeons say, well, we don't want an A-line, it still means that you can use flow-directed therapy, which is very useful. Because I think one of the problems is if it's a small unit is you don't want to be training people on lots of different platforms. You just want one platform. Yeah. Because also the techs need to know.
I do have one last comment if it looks like we're winding up here. I think Mike asked me up on this panel for diversity, not because I'm a woman, but because I'm a Neanderthal surgeon. And he proved it when he started talking about bananas.
Thanks, Tony. Good. Any other questions? Because if not, we'll close this session. Thank you very much.